Today we're going to talk about rotator cuff tendonitis, and I say it's a common injury because anyone can get it anytime, and it can be due to mechanical flaws of the upper extremity. It could be from using it very hard. If you did a weekend of work outside and you've been hammering, you get the tendonitis. Overhead use repetitively can cause the tendonitis, and we know this can eventually go into rotator cuff tears. But we should know our muscles of the rotator cuffs and the primary actions for it. The acronym is SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. And they all have multiple functions. If you're not familiar, I would go back to your anatomy book and review. Most of them aid in external rotation, except for one does internal rotation. And if you're not familiar, I will reveal that at the end of this presentation. So tendonitis, we know that it's an inflammation of the tendon, okay? 90% of all pain in the shoulder is caused by this tendonitis. And the reason why we have such problems with our shoulders is because it's not as stable as it is the hip. The glenoid fossa and the head of the humerus are non-congruent. We do not have a very good labrum around the shoulder. We do not have a vacuum. The head of the humerus is 3 times too big of the size of the glenoid fossa, so it's not congruent in terms of musculature. It is very much has muscles for stability. It does not have that bony congruency that we would like to see. And also the concave nature of the glenoid fossa is not there. So there's a lot of stress put on the shoulder with really relying on dynamic stability of the muscles in order to do that. And if you have muscles that are being stressed, so are the tendons. And when you have a lot of stress, you have inflammation. When you have a lot of inflammation, blood flow goes down because there's not a very good blood supply to them. And the tendons of the shoulder do not have a very good blood supply, which means the healing process is very slow. And sometimes you get stuck being in that inflammatory process. Most healing takes on the form of scar tissue. So many times we need to break up that scar tissue, that type 3 collagen, in order for it to be transformed into type 2 collagen with positive stresses in order to realign those fibers appropriately to gain strength again. Okay? Supraspinatus and infraspinatus, your supraspinatus tendon, where much of the tendonitis takes place is hypovascular. I have the O in blue there, meaning low. It does not have that good blood supply. And so one of the things you need to do when evaluating the shoulder is you have to find the pain, not a pain, so that you can concentrate your efforts on a specific structure. And one of the things you need to do is depict between contractile and non-contractile units. So what's the difference? Contractile should be just that. It contracts. It has contractile properties. And if you notice, this whole list are all muscles. They're contractile properties. Okay? Your non-contractile or inert structures are those of ligaments because ligaments cannot contract. So we have the acromioclavicular ligament, our coracoacromium and coracoclavicular ligaments. Okay? And those are the ones that bind and hold the clavicle down. Now, Cyriax was a great investigator who evaluated the shoulder and gave us much good evidence-based practice that is out there. And he states that all pain has a source and that all treatment plans must reach the original source. Okay? And it has to be the ones that help appropriately. So you have to do some investigating before you go treat the shoulder. You really want to figure out what the source of pain is. Okay? Before you do anything with the shoulder, though, you always have to be concerned above and below the joint. And anytime you're dealing with the shoulder, you want to make sure that the neck is in a positive posture and you rule out any injury of the cervical vertebrae. Many times people have a shoulder pain, but the source is coming from the neck. So you really have to be weary of, did we rule out any type of cervical injury before we just assume it's coming from the shoulder? So you really want to ensure that the range of motion, both active range of motion and passive range of motion, is there for the patient and that it's not any type of referred pain that's occurring. So what you're going to look for in your evaluation is how do they move? Do they have full range of motion? How much pain do they have? You want to check passive range of motion, and do they have any type of end fields? Is it leathery? Is it foggy? Is it a bony block? You want to look for any type of abnormal biomechanics. So you're going to be looking mechanically of how do they stand and how do they move and what does their posture look like. And you're going to look for a painful arc in both flexion and abduction. And when you do abduction, one of the things you want to ensure is that in order for you to get that good inferior glide, you want to externally rotate so that your thumb is out and your palm is facing forward, and then you go into full abduction. If you have your thumb in and go into abduction, go ahead and try it. Thumb down, go into abduction. What happens? Okay, you no longer can go into abduction at approximately 110 degrees. That's because you're not having good arthrokinematics. There's not good movement. There's not that inferior glide going on at the head of the humerus. Your head of the humerus has now been blocked by the clavicle. So let's do it one more time. Thumb down, go into abduction at 110 degrees. Now what I'd like for you to do is externally rotate your arm so that your thumb goes up. The head of the humerus has now cleared the clavicle, and continue going all the way up. Okay, so you want to make sure that they're doing their abduction appropriately, and do they have pain anywhere along that arc? And there's usually a 13-step process that you should do according to Cyriax in doing things, your evaluation appropriately. So you first want to check active and passive range of motions, but in this order. First, abduction, and you're looking for any painful arc continually throughout this process. If you have a painful arc in abduction, both active or passive, start thinking, is there an impingement or is there bursa? Okay. Passive abduction from 0 to 90 with passive external and internal rotation. You then progress onto resistive abduction, adduction, resistive external, internal, elbow flexion and extension, and also horizontal adduction. And horizontal adduction is if you're standing up straight with your arms abducted to 90 degrees, you're going to put your thumbs up, okay? And what you're going to do is now adduct and end up with your hands directly in front of you. That is horizontal adduction. And what you're testing for is subscapularis and the AC joint. Okay? So interpretation, what is it? Okay? If you have full painless abduction with passive range of motion and painful arc with abduction, okay, you could be thinking supraspinatus. Okay? It's that painful arc and abduction that is going to really trigger superior fibers of the supraspinatus. Okay? Supraspinatus inferior fibers is going to have full passive range of motion with pinching at the end range with very little painful arc. Your resisted abduction is going to be painful and the person's going to be weak with a lot of point tenderness on the greater tubercle. You can differentiate and feel the greater and lesser tubercle when you go into a flexed position, arms at the side, bring your elbows up to a flexed position, so it's a 90-degree angle. Okay, with your left hand, I'd like for you to palpate and feel the anterior portion of your shoulder. Go find the head of the humerus. And what I'd like for you to do, okay, keep your hand on the head of the humerus, and I'd like for you to internally rotate all the way, and that would be the greater tubercle. When you come to about 90 degrees to your original starting spot, you should be feeling the biceps tendon. And go ahead and palpate pretty hard there. You'll feel it. You'll feel that discomfort. Now, when you externally rotate from that neutral position, you'll be able to palpate the lesser tubercle. Come back in to neutral. That would be biceps tendon, internal rotate, and you are on the greater tubercle. Your supraspinatus joint is going to be more of the musculotendinous junction, and here are your signs and symptoms that you would have. Remember, you need to differentiate so you know what structure you're going to be treating appropriately with both therapeutic exercise and probably modalities. Take a read through your infraspinatus and teres minor. These are your tests and evaluations that will lead to that diagnosis. And next you have your subscapularis. Okay? This is your key, resistive internal rotation. Remember at the beginning, I talked to you about the rotator cuff muscles. It is the subscapularis that is responsible for internal rotation, and that's because where the muscle is located, okay, which is underneath the scapula. Okay? What do we do for shoulder tendonitis? Well, we have to decrease the inflammation first and decrease the pain. We got to stop anything that's aggravating it, and usually we're going to do some type of modification initially of activities of daily living. That's number one. What we do need to do is look at, what's happening to it. So what I said when we're talking about patellar tendinitises work very well with eccentric muscle contractions or lengthening of the muscle contractions. What we don't want to do is someone to be in so much pain that they don't do rehabilitation. And rehabilitation is very tricky because of that hypovascularization, that decreased blood flow. So sometimes we actually have to increase inflammation in that area to get the blood flow coming back in. We need to re-aggravate it so we can get those chemical mediators there. So if someone does not do it because it's painful, okay, things can happen. People can go into immobilization, self-immobilization. They don't move. And now they're going to have muscle contractures or muscle shortening that has occurred. When you have muscle shortening that occurs, you are going to change your mechanics of your body and maybe go into a rounded shoulders, where now you're going to have contractures anteriorly, and posteriorly you're going to have things stretched out, and that's going to really affect the scapula. Okay? When you go into self-mobilizations, you're going to have decreased amount of movement, decreased synovial fluid, and now we have all those effects of immobilization, softening of articular cartilage, decreased nutrition. Okay? And when that happens, you have breakdown of all fibers. You have breakdown of cartilaginous fibers, breakdown of muscle tissue, and things become weak. So stretching, how are we going to stretch? You can have people do automobes, which is a self-stretching. You can do joint mobilizations, where you're really trying to restore those arthrokinematics, and there's two really nice videos on how to do joint mobilizations. A lot of table activities, prone prop, which is just going into that semi-plank position so that you're doing a positive stress in the shoulder. Okay? You do want to put a towel under the arm during exercises just so that you have it in a neutral anatomical position. That's something very important when they're doing any type of TheraBand activities, that there's a towel put underneath the axillary region so that it keeps the shoulder in neutral. Okay? And I like using towels or bars to do any type of internal external rotation, like if you're coming out of the shower and you stretch as if you're trying to dry your back. That's internal and external rotation stretching that you can do, but just make sure you change positions and change hands. Strengthening, many times we'll do cross friction massage because we want that inflammatory process to come back in, especially if it's been stagnant for so long. TheraBand exercises are fantastic in 4 directions, doing diagonals. There are 2 videos posted for you so you can see the D1 and D2 proprioceptive patterns. I call the D1 feeding your face because you're bringing your arm diagonally in towards your face. The D2 pattern is if you were taking a sword out of your pocket and coming out. We may do lat pull downs, we can do pulleys, we can do scapular stabilizations. Because remember, the shoulder complex is not just the glenohumeral joint. You have to think about the clavicle and, of course, the scapula, which are all embedded into the shoulder girdle. So what you do at the shoulder impacts the scapula. What you do at the scapula definitely goes and impacts the glenohumeral joint. Okay? What else can develop? You could get calcium deposits underneath the tendon due to tendonitis, which is underneath the subdeltoid bursa. Okay? I want you to think closed chain activities. Closed chain activities, first of all, build up strength, whereas open chain is going to be functional. There's many things that you can do that's closed chain. Walking on the treadmill with the hands would be closed chain. Stair climber. Please share your activities with the class. We're going to talk about them in forums.